Once again, we talked to Professor Stephen Faraone, the president of the World Federation of ADHD, the professor at the sunny upstate University of New York, and founder of ADHDevidence.org, a platform where you can go through the most important recent papers on ADHD. They are well described there. It's always a measured, balanced description of those studies, which I like very much. And so I'm talking to our audience. I really recommend going there and going through those descriptions. And so today we will talk once again about a few of the recent papers on ADHD. And the first one of them will be the one written by you, Stephen, and Jeffrey Newcorn, where the paper is called Rethinking the Role of Non-Stimulants in ADHD Treatment. And let me first introduce the paper to our audience. We doctors, usually when a patient comes with ADHD and we think that pharmacotherapy is necessary, in this case, we usually go straight forward to thinking about using stimulants in treating of the patient. While the paper argues that this thinking shouldn't be that straightforward. I mean, I will let you speak in a moment. As far as I understand, what you were trying to say is that we should be more balanced in our thinking, and there are a few reasons for that. So the first one being that the difference actually between in efficacy of those two drug groups are not that it's not such a big difference between efficacy of stimulants and non-stimulants. Then there's it's also, one should remember that when we do studies on stimulants and when we blind the study, it's quite difficult to blind the study because stimulants usually have quite clear effect on the person. So the person might know or might think that she was given a stimulant, and this of course affects the placebo, so increases the placebo effect. Then there's another problem with stimulants, saying that of course, these are regulated medications that we doctors have to use special prescriptions. Our patients have, I don't know how it is in America, but in Poland, quite often they are facing scrutiny. Also in the pharmacy when they pick up their medications, and many patients say that. How to call it? It's
a headache.
It's a headache. They would prefer to get a normal, let's call it, medication, not the one for the special prescription.
Yes,
regulated. And there's also the possibility of abuse of those medications. So these are just a few points. Did I miss any?
No, you've hit the main topics of that paper that Jeff Newcorn and I wrote. And you're right that in most, for example, in the United States, all the treatment guidelines suggest or imply, depends on the guideline. I'm talking about guidelines for pediatricians and psychiatrists, that one first start with the stimulant medication. And if that doesn't work, and sometimes start, if the first stimulant, go to another stimulant. Only if that doesn't work would you move to a non-stimulant medication. And the reason for that is simply the historical data on randomized controlled clinical trials that show that on average, stimulants are more effective than non-stimulants. And what we show in the paper, we'll talk about effectiveness or efficacy of the medication first, that we show that, as you mentioned, the difference isn't that big. It's roughly, the the probability of somebody responding better to a stimulant versus a non-stimulant is roughly 56%. 50% is the flip of a coin, so 56% isn't much greater. But we also think that the effect of stimulants has been overestimated because, as you mentioned, you feel a stimulant, you can, it may raise your blood pressure a little bit, heart rate goes up a little bit. One can feel that. You have the adverse effects, a little bit of insomnia, and that can increase the response that a person feels because of placebo effects. But perhaps the most important thing is a misunderstanding among doctors, but also among people who do guidelines about what the efficacy data mean. I think many have taken the efficacy data to mean that stimulants are better for everybody, and that you can't do as well on a non-stimulant as you could on a stimulant. And actually, that's not true. And what we present some data, for example, that show that if somebody is on, there's been studies of the non-stimulant called atomoxetine, which I believe you have in Poland. Roughly about 40% of people given that atomoxetine can do really well as they would do on a stimulant medication. But if you look at treatment data around the world, and I've done this, basically in most countries, and it varies with country because of availability of medications, but roughly 90% of people treated for ADHD are on stimulants, and 10, maybe 15% are on non-stimulants. So if the response rate is 40%, that means there's a lot of people who would do well on a non-stimulant who just aren't on them. Now, the second problem you have is there's some data, there's not as much data on this, but there's some data to suggest that that being non-responsive to treatment is a kind of a general characteristic. So if someone's on a non-stimulant, they try it on 2 and they're not responsive, as you know, that's probably a pretty complex patient. And when they're given non-stimulants after that, many of those don't respond because they're just difficult patients. They're when I say difficult people in the audience, I'm not saying that you're a bad person. I'm just meaning that your disorder is more difficult to treat for a variety of reasons. It could be the context of your environment. It could be the nature of your disorder. So then what happens with that is that when the doctor tries non-stimulants after stimulants, they get the impression that these just don't work because the response rate is not 40%. It's lower than that. And so that's another problem we have with the whole efficacy side of things. I'll stop there for just a second, for a little bit, to let you ask some questions before I move on to the other points.
Okay. So I just want to make my position clear, because when I teach doctors about how ADHD should be treated, I always say that each patient is different and there's no standard treatment in ADHD. Of course, what you say is true about what the guidelines say, but it's funny because just 2 days ago, I had a big meeting with patients, and patients ask nearly all the questions are about stimulants. And when the first question was asked about a stimulant, I said, first, I need to make a disclaimer that each patient is different and there are different medications. Luckily, we have around 10 medications for ADHD in Poland. And we should always think about which one of those 10 will be the best for this patient. So I completely agree with you, but so let me argue that there are a few things that, on the other hand, I understand. For example, in America, I know from studies, from publications, that most of children are treated by pediatricians.
That's right.
I mean, children with ADHD, right?
Yes.
That many GPs treat ADHD in adults.
That's right.
It is my understanding, please correct me, it is my understanding that those doctors do not spend much of their time taking care of only ADHD patients. They have different patients.
That's exactly right. Yep.
right? So I understand that they need clear guidelines where to go, because I admit I consult only, well, not only, but 99% of my patients have ADHD. But as I say, there are doctors who have different patients, and for them it's more difficult, probably more difficult for them to decide whether they should go to non-stimulant or stimulant. And in the group of non-stimulants, there are different medications which also have different properties. And in fact, I would still divide it into different types of non-stimulants, and
For sure.
to say, right, to say that
Right.
okay, when the patient is obese, maybe you should go with this medication first, and maybe if the anxiety is the first or the foremost symptom of the patient, maybe you should think about this one. So so it's so I completely agree that we have different means, different tools, let's call them, in our fight with ADHD. It's just that not all the doctors have the expertise. What do you think?
Well, that's true. In the U.S., the pediatricians have been treating ADHD for decades. So, for children, they're pretty well trained on how to treat ADHD. In terms of treating adults, though, the general practitioner that treats adults, many of them have not very well trained at all, because adult ADHD, as you know, is relatively new, and has only really, the treatment of it really only began to emerge in the early 21st century, based on work that me and some other people did in the 1990s. So that's why guidelines are essential. My worry about the guidelines is that when they're adhered to strictly like this, they've created this problem of too much stimulant medication. So we ought to discuss, really why is that a problem? And you mentioned the public health issue. Well, there's really two issues. There's the difficulties, the headaches patients experience because these are controlled substances, and by controlled we mean because they have the potential for addiction. They have to go through certain regulatory procedures that require paperwork, more difficulties at the pharmacies. There's also been stimulant shortages, which create a problem, and the shortages are related to the fact that they're controlled substances. On the other hand, non-stimulants are just ordinary medications. They're not controlled substances. Now, I should be very clear here that although stimulants are classified as addictive substances, their therapeutic use does not cause addiction. And it's just the reverse. We know that the therapeutic use will prevent addiction, will help people not to become addicted to alcohol or drugs. That's very important to understand. But nonetheless, because they're addictive, they're controlled. So in the U.S., we have a problem that I wouldn't definitely not call it an epidemic. It's a small but growing problem. Well, is it growing? It's probably more stable than growing, where particularly adolescents and young adults will get access somehow to stimulants because they'll buy them on the street. They'll get them from a friend who has ADHD, and they'll use them in what we call a non-medical way, meaning a non-prescribed way. The two main ways are they use it because they like the feeling, so maybe they're trying to get high from it. And the second way is mainly they use it to basically stay up late at night. So college kids, if they want to go to a party and stay up late, they get tired from alcohol, they'll take a stimulant to wake them up. Or they might use it to study, to stay up late to study. This is the kind of problem that we don't need, and you don't need in Poland. And it would be reduced if we could reduce the amount of stimulant medication that's just out there in the world. And we would reduce it pretty dramatically. And we discuss this in the article, by a few million prescriptions if we switch to a model where non-stimulants were considered to be an alternative as a first-line treatment to stimulant medication. And it wouldn't affect the quality of care because everybody would get the treatment that's efficacious for them. But it would reduce the availability of stimulants to the public, which we think is a good thing.
Yeah. Once again, I agree. Thank you very much for saying first that the stimulants used under proper supervision are not addictive or do not lead to addiction. And second thing, thanks for saying how they work and why people without ADHD use them, because as you are certainly aware of. At least in Poland, probably 99% of the population think that when you use amphetamines, you get brighter and more intelligent.
Mm-hmm.
And as studies have shown, David Cockhill did a study
Mm-hmm.
showing that stimulants actually only increase the alertness, but they do not give you more intelligence. Or
that's right.
there was even, I don't know if you know, but there was even a study showing that people who take amphetamines think they are brighter when they take amphetamines, but when tested, there was
that's
a study.
They're actually right. It's not actually helping people think more clearly or better. It's just making them more alert. You can stay up longer on a stimulant. Take a high dose, you could stay up all night on the stimulant medication.
Yeah. So thank you very much for writing this paper, and I hope it will be a source of some discussion about it, because certainly.
Well, I should add that Dr. Newcorn and I are now funded to do a very big study in the United States, where we'll have several hundred children in a protocol where we'll compare two pathways. One is try 2 stimulants first before you go to a non-stimulant. The second is try 2 non-stimulants first before you move to a stimulant medication. And that will provide some evidence about a long-term efficacy, because we'll follow the kids for a whole year to see what is the actual difference in outcome between these two methodologies. So we think that's will produce very useful data for clinicians and also for parents and patients to kind of evaluate what's really the best treatment for the individual, as you said, which needs to be a kind of a collaborative decision between the patient and the doctor about how to move forward on that.
Of course. To just the last point is to make what matters even more complicated. Those, like you said, your study is in children, and the study that you mentioned in the paper showing that it takes up to in the study that you mentioned, it's written that after 4 weeks, the effect after 4 weeks can be used as a predictor of the effect of atomoxetine.
2 weeks. 2 weeks. The effect after 2 weeks.
Okay, I might be wrong.
2 weeks. No, it's definitely 2 weeks.
But anyhow.
Yeah.
Okay. Anyhow, in the case of adults, usually higher doses are used, and it might take more time. And, with ADHD's impulsivity, this might cause the problem. I mean, the patients.
Yes, you're absolutely right. It's another reason why practitioners like the stimulants, is that the effect is much quicker, and they can get a better sense very early on of whether the patient's going to respond, and the patient will respond sooner if they're a responder. And I understand that, but it's really, we're weighing, you're always weighing different outcomes, right, in healthcare. And what I think is that practitioners haven't really weighed the public health implications of stimulants enough. And they've overemphasized this, how quick they work. So, for example, we know that most people and most kids, most adults with ADHD have had it for a while before they come to the doctor, right? So they may come to your office. An adult might have had ADHD for 20 years. A child may have had it for 2 or 3 years. So I have to ask everybody, why is it all of a sudden so important that we get a treatment that works in 4 weeks after you've had a disorder for 2 years? Maybe we could wait for a month or 2 months to get the best treatment that might not involve all of these regulatory headaches and risks for misuse of the medications. That's the question I'd ask. So what do you think about that?
Okay. So first of all, believe me, I spend lots of the time during my consultations talking and explaining as much as I can during the time that I'm given to the patient. So, like you said, I would say that each decision is made together.
Yes.
And I just give the information to the patient, and we together establish what will be the right treatment in this case.
That's right.
And so I spend a lot of time talking and describing different groups of medications, how they work, and what are the benefits and risks of both. But I would say 70% of patients, it's very common that parents come with a child who will have the exam in 1 month's time.
Mm-hmm.
The child wasn't treated for 17 or 18 years.
Mm-hmm.
And now they say, doctor, we have the exam in 1 month's time. We need to start the treatment.
Mm-hmm.
And usually patients and adults parents of patients, they want to start being treated right away. And as I say, when I talk to the patient, so for me, the decision or the view of the patient is very important.
Absolutely. In the U.S., we call that collaborative care. That's a new model. That there's a collaboration between the patient and the prescriber as to what's the best approach. And clearly, I mean, ADHD is very variable. And some patients there is a more urgent need to treat quickly. Some patients with very severe ADHD, you would evaluate the risks and say, I think your risks are pretty high for maybe an adult could have a traffic accident because they're so impulsive, or they've had many accidents. And there, the issue of how quick the treatment is becomes important. I should elaborate on the point you made about the 2 weeks prediction. Is that what the point in the paper there was that although non-stimulants take about 4 to 6 weeks, sometimes 8 weeks to show their full effect, what we showed in some papers, me and Dr. Newcorn, different papers, one, he did it for atomoxetine, I did it for viloxazine, which is we have in the US. I don't know if you have it there. And what we showed there is that basically after 2 weeks, the physician could make a decision about whether to keep the person on the non-stimulant or not. Because if they're not showing response within 2 weeks, would make sense to switch to another medication. And that at least shortens that time from, it doesn't have to be a 4 to 8 week waiting period.
So let me repeat, I agree with you. And we don't have viloxazine. The registration studies for viloxazine show that 2 weeks, and this is I would say, difference between viloxazine and other non-stimulants, that the first effects come quite quickly. I mean, I have no experience, like I said, but from the registration studies, I know that from your study, of course, too. So, in the case of viloxazine, this is something that we can surely expect earlier, whether the medication will work or not. Like I said, we don't have viloxazine. That's why I'm not talking about.
Dr. Newcorn showed a similar effect for atomoxetine. That the early response was a good predictor of a later response. So.
Okay. Let's move on to the second paper. The second one is called Attention Deficit Hyperactivity Disorder Traits in Childhood and Physical Health in Midlife. Wow, we know a lot about negative effects of ADHD. And when a new study shows up showing some more negative effects, shorter life or life expectancy, or you mentioned accidents, higher rates of suicidality, and different. I don't know if you probably know that during the COVID pandemic, people with ADHD had higher rates of getting COVID. So I always think, should we talk about it or not? But on the other hand, what is we should prepare? In my opinion, we should be aware, right? We should be aware.
What if physicians do in other specialties, right? They always talk about the disorder, its outcomes, its prognosis, right?
Yeah.
We have the term prognosis. What is the outcome of a problem if it's not treated? And that's important for patients to know, and families.
Although when I'm giving interviews, I'm always trying to have a balanced opinion of ADHD. I mean, what I'm saying is I'm always trying to say that there are good and bad outcomes of ADHD, and one should remember about both. But that's another. That's not
Well,
neither here.
I would say it a little bit differently. What I would say is that the research has demonstrated that there are some outcomes of ADHD that are of concern, but we're not trying to get people upset about this because the outcomes are not everybody doesn't experience these outcomes. But some people do. And so it's up to you to decide whether you'd like to try to protect yourself or your child from the possibility of these outcomes. But we don't want to worry people. For example, the data on premature death in ADHD, it's a small change. It's real but small. And it's mostly due to accidental injuries, which are preventable, and suicidality, which is difficult to prevent, but it is preventable, but with treatment. And it's a good example of how it's not like we're sentencing people to a horrible life of outcomes. We're saying these outcomes can occur, but if you have treatment, they're much less likely to occur, which we know from some of the data.
If you are aware of those risks, you can protect yourself, right? That's why we are talking about it.
Exactly. It's just like, my doctor tells me your cholesterol is a little too high. You really, the risk of your risk, you have a risk for stroke or heart attack if you don't take this medication. I need to know the risk before I decide to take the medication, right? It's the same thing.
Yeah. So in the study, they followed 11,000 boys. I think it was sorry. It was both women and men, and they followed them for until they were 46. And they checked whether those who reported higher load of ADHD symptoms, because they did not base on ADHD diagnosis proper, they just did questionnaires and looked at whether those people or children displayed ADHD symptoms, and so they looked at whether there was a correlation between what was the load or burden of ADHD symptoms in the childhood towards the physical health outcomes in midlife. So when those people were 46-year-old. And they really did find correlation there. So the more symptoms of ADHD you have, this of course affects your midlife physical health. Do you think that this model of only checking the level of ADHD symptoms with questionnaires instead of doing a proper diagnosis, do you think it could somehow affect the results?
It will affect the results for sure, because having a lot of symptoms is not the same as having a diagnosis. That's important for people to remember, that a diagnosis is based upon people having a lot of symptoms, but also having the symptoms early in life, and those symptoms showing substantial impairments or difficulties in more than one context in one's life. So in this particular study, we can only say what's the impact of having symptoms of ADHD. Now, having said that, I should also say that there's a pretty good correlation that in a study like this, people with lots of symptoms, many of those people will also have ADHD. And it's a very big study from what I think you said. So there are some statistical details we don't have to get into, but having a very, very large study will tend to help deal with what I call the noise that comes from using symptoms instead of diagnoses. It's also true, though, that we know from some of the genetic studies that have been involved in that when we ask the question, what is the genetic basis of the disorder defined by doctors? What's the genetic basis of symptoms, just as a count in the population? It turns out that they basically are the same. That the genes that cause ADHD are the same ones that are causing the symptom variation. So the symptom variation in the population is definitely relevant to ADHD. So I don't dismiss these studies and say, oh, they're useless. On the other hand, I say, no, they're very useful, but we always have to be a little bit careful that it's not the diagnosis, because sometimes that does make a difference. Sure.
Okay. So patients very often, when I talk about negative impacts or negative effects, outcomes, I guess is the best way to describe it. What are the outcomes of ADHD? Patients often ask, what do you think, doctor, leads to shorter life expectancy, for example, or some other? Yeah, they usually ask about a shorter life expectancy, because, of course, that's the most important. And what do you think? What do you reply to such people when they ask you about that?
Well, I'd say in general, for shorter life expectancy, we know that it's mostly due to accidental injury and suicidality. Very little can be accounted for by other issues. Some of it is due to psychiatric comorbidity. So if a person has another disorder like substance abuse, that can also contribute to it. As a more general question, let's say medical disorders, we know ADHD increases the risk for hypertension, diabetes, other cardiovascular outcomes. The answer is more complicated. And I'd say there's two pathways that are being looked into. We know for sure from the genetic studies that the genetic, I'm going to say genes, it's a little more complicated than just genes, because genetic risks are also parts of our DNA that do other things besides being genes. But look, we're going to say genes to make it simple. That the genes, if you will, for ADHD, and there are a lot of them, we think there are probably 7,000 bits of DNA that affect ADHD. Those genes, some of them, not all of them by any means, but some of them are also risk genes for obesity, diabetes, hypertension, and other of these outcomes. So we call it a genetic correlation, that the genetics of ADHD is correlated with the genetics of obesity. It's not the same, but it's correlated. And that means that, and we don't know the details, but for some reason, the underlying biology that's causing ADHD is making somebody predisposed to these conditions. That's one thing. The other side of it is that we know from anybody who knows about symptoms of ADHD, who has experienced them or treated them like yourself, knows that these symptoms could lead to poor, we'll call them disease management behaviors, or poor lifestyle behaviors. So if a person is an impulsive eater, well, they're more likely to become obese. We know, I've done some studies in the area of diabetes, where what we've shown, and not just my group, but other groups have shown this now, that people who have ADHD and diabetes are less able to control their HbA1c levels than people who don't have ADHD. But simply, that just means they're not managing their diabetes as well. So they'll have worse outcomes because maybe they forget their insulin, or they're eating something they shouldn't eat. And so there's a behavioral pathway, there's a genetic pathway. What I tell people is that, we can control our behavior, so we should really focus on that. And I tell physicians or any healthcare people that you really need to know if your patients with diabetes or other disorders have ADHD, because they might need special attention, or they may not even be diagnosed, and they might actually need treatment.
Do you think that thanks to this paper, we could say something to our patients, what they should watch, or where should their attention go to if they want to have better physical health in the midlife? I just want to say that in a moment we will be talking about the paper showing physical activity and the effect, but we will be talking today about physical activity and cognitive properties or functions. Sorry, is there anything that we can tell to our patients who are watching what they can or what they should think about if they want to have a better physical health in the midlife?
Sure. Before I answer that question, I do want to mention that what we're talking about is not just based on this one paper. The one paper is interesting and is more recent, but there are now a lot of papers that have come out, some with diagnosis, using the diagnosis of ADHD, that also show this increased risk for other disorders. There's a big consortium out of Sweden that I participate in called Timespan. We have shown many cardiometabolic disorders are increased in people with ADHD. Now, people have to understand, when I say increase, I don't mean a lot. I don't mean everybody with ADHD gets diabetes. No, it's far from that. It's a small group, but there is a little bit of an increase. To answer your question, my view of it, and this is, the advice, for example, I have a son with ADHD, and I give him the same advice, which is, you, like everybody, you need to take care of yourself, but a little bit, maybe you need to pay a little more attention to that because you have a little bit of higher risk. It's what we say for any high-risk group, right? If you have a high-risk group, that's a group that doctors need to screen more often. So the doctor needs to say, okay, this patient, maybe I need to see more frequently for their physical to make sure these disorders aren't emerging. And if you're a patient or a parent, it means, especially as you approach midlife, that you need to attend to your health perhaps more vigorously than the average person. And that's all good. It's really, eat well and exercise, right? Those are the two main things we can do for our health, for sure. And then get screened regularly by your physician so emerging problems can be caught, because most of these problems can be dealt with. Hypertension is not a big deal if you catch it early. It's deadly if you don't. So see your doctor on a regular basis. That's what I say.
Yeah, thanks. Okay, the third paper is the one, let me make an introduction. Many patients, we talked today about how people with ADHD, being impulsive, they usually want to get treated right away and get the effects right away. And often, whether they get or are offered the medication or not, they often ask about different methods for taming, let's call it, the ADHD. Of course, in our offices, they always hear about psychoeducation and psychotherapy of ADHD, and that this is the most important part of ADHD management. But anyhow, they often ask about different methods for getting better.
Yes.
And so, as you know, patients often ask about biofeedback, let's say, or other methods. And as FDA, when did FDA approve this trigeminal nerve stimulation procedure?
It was a few years ago. I forget exactly.
A few years ago, I had it somewhere. But okay. Anyhow, 2019. And this was based, the approval of FDA was based on a small control and randomized study in 62 children. And right now there's a new study, a bit bigger, because 75 children in the control and in the active group. And this study, unfortunately, showed that there's no effect, absolutely no effect of TNS. How can we comment on that? One study controlled with sham and showing positive effects, the other one, no effect whatsoever.
Well, as they say, the devil is in the details. So I'll go into it for you in some detail.
Please.
First, I'll comment that you said that trigeminal nerve stimulation was approved by the FDA. Actually, it wasn't approved. It was cleared by the FDA. There's a difference that people need to understand about regulatory agencies. Drugs are approved, but devices that are not drugs are cleared. And there's a big difference. Because drugs, there's a big concern about side effects, long-term effects that might occur. The studies that are done are large and rigorous. Usually 2 large clinical trials have to show an effect. As you mentioned, for the trigeminal nerve study, it was a very small study of 60 people. It was a good study. I know the investigators, top group of investigators did the study in the US. The second study you mentioned, again, a top group of investigators, very good people, did a very good study. So why are they different? Well, the discussion that has occurred in the field at meetings about this, because we've known about this now for a while, because we get to see things before they're published when we talk to our colleagues. The people at UCLA who did the American study, what they think is that the European study had a placebo group where the sham group was actually too effective, because the sham group was getting a little bit of stimulation, something along those lines. And they thought there actually may have been some efficacy in the sham group that diluted the effect, and therefore they didn't see it. UCLA is now running another study to try to look at these issues. So what I would say is that, we don't have the final answer yet. I know the European group thinks that their sham was fine, and they would make the argument that it's fine. I'm not saying which is right. I'm just kind of telling people what the discussion is. This is what happens in science, right? You have when you have results that are conflicting, the researchers that did the work, they go on to figure out why are these results conflicting? Did UCLA just get lucky? Was it just a chance finding, which sometimes happens, which is why you need replication, or are they correct about the sham? We'll find out, but it may take a while before we do. It's kind of a shame, because I was pleased when I saw the trigeminal nerve stimulation. I thought, well, this is great. We have a non-pharmacological treatment that had a pretty strong effect as well. It wasn't a weak effect. It was a pretty strong effect. It could be pretty valuable, but we'll have to see now. We can't really strongly recommend it given the negative trial that came out of Europe recently.
So just to sum up, still no instrumental method for treating ADHD, just so the patients can hear that.
Exactly.
And as far as I remember, the Lancet study showing from 2024 showing the efficacy of different ADHD treatment methods says that if someone wants to try them, okay, but there's no recommendation to treat it, to use them, those methods. Is it?
Well, yeah. I mean, of course, if a patient wants to try something, nobody can stop them. But what I tell people is that you really need to use evidence-based methods that have shown to work. Because if you use a method that's not effective, it's essentially wasting your time. And
I do too, but we are
risks.
Scientists, Stephen.
Yes,
we are scientists, and that's why we say that.
Exactly. That's
and
right.
Ordinary people often try to help themselves any way they can.
Well, I would tell people, many of us have seen these old movies from like the American West, where somebody is selling some, we call them snake oil salespeople, right? Where they're selling some medicine to people that they say is going to cure all sorts of problems. And we look at that in the movie and we say, this is ridiculous. People actually did it, and people actually brought those fake medicines. Many people did it and were fooled. And when I say to people that we have snake oil salespeople nowadays who are selling things that don't work, and you really need to. I recommend people be very cautious of that, because I understand people that are afraid of medications. Like I said, I'm a parent of an ADHD person. I know what that's like. But you have to balance the risks of not getting effective treatment versus the risks of the potential of the treatment itself, which are small. I think one thing I realized I forgot to remember about we talked about cardiovascular risk and ADHD. Importantly, those studies have shown that the risk for cardiac outcomes in those studies is not due to taking the medication. Because sometimes people are worried about cardiac risks for ADHD medication. And as you know, as long as somebody has been screened for prior cardiac problems, every regulatory agency says there's no problem with cardiac risk in ADHD.
Yeah. Actually, I was trying to say that the last time that we talked, but didn't want to make it very strong. I mean, okay. Thank you.
We know with the stimulant medications will increase the risk for hypertension, and that's more of a problem in adults and kids. But that's easily monitored and controlled by doctors. It's something that it's easy to deal with. But in terms of serious cardiac events, those have not been associated with ADHD in the many studies. And when every now and then a study comes out that looks at maybe 10 cardiac things and they find one, those are usually relatively minor, and they've not been replicated by other studies. And so in general, the field thinks, no, these are not real. And the regulatory agencies do too. That's what I looked at the regulatory agencies. How do they respond to them? Because they're very, regulatory agencies are very, what's the word for it? They're very serious about monitoring adverse events. I don't know if people know this, but for example, the EMA in Europe, the FDA in the United States, they don't just approve drugs, they monitor them and they monitor reports of adverse outcomes over the years. As long as the drug is out, companies in the U.S. are required to do this. And if, for example, as you know, H-tamoxetine has what's called a black box in the U.S. for suicidality, because there was some evidence that came out. It wasn't very strong. It was actually weak evidence, and some people argue wrong. But in any case, the FDA was being very cautious, and they said there is a small risk of suicidality for H-tamoxetine. So it's very important that I think people understand that when we talk about ADHD putting people at risk for cardiometabolic outcomes, it's not the medication, it's the disorder itself for the reasons we discussed.
Yeah, and let me just remind our audience that we should always also weigh the effect of them, even if there's some negative effect of the medication, then we have to weigh it against negative effects of not being treated, right? And that's usually huge in many instances. Let's go to the fourth paper, the impact of exercise interventions on sustained attention for children and adolescents with ADHD, a systematic review and meta-analysis. We scientists love those meta-analyses.
We do.
Right. And actually, this is a group that I think often does meta-analysis in ADHD. Anyhow, so they reviewed 11 studies, altogether 540 children. Those were not very large studies, usually 60, something like that, children. But anyhow, those were studies with different kinds of exercises. People will probably would probably want to know how frequent were those, because patients always ask, okay, but how often do I have to exercise, and for how? Every day for 10 hours. So let me read just a few as examples. So 30 minutes for 30 minutes session 3 times a week. Then 40 minutes session twice a week, 45 minutes 3 times a week. There was one 65 minutes 3 times a week. And usually for a few months, like 2-3 months. And there was a huge impact on cognitive performance in those children. So, well, we can't overstate the significance. I don't know if you can come up with something new. I can't, I think, saying how important it is for children and for adults with ADHD to do some any form of physical exercise. I usually tell parents, if your child wants to change the sport every week, if you can afford it, go for it.
Go for it. Yes, absolutely. Well, first, yes, exercise is essential for all kids, not just kids with ADHD. It's essential and also for adults. I mean, if people want to improve their health overall, eat right and exercise. I mean, it's simple advice that's been given for decades, if not centuries. The specific effects on ADHD are open to debate and discussion. We know that you can't expect exercise program alone to dramatically reduce the symptoms of ADHD. That's been shown. There may be a small decrement in symptoms, but it's not a big effect on symptoms. This study happened to show some consistent changes in cognition, but whether that actually yields any real-world gains, for example, in school performance, is not clear. Because many times we have seen, well, it's one thing to say that ADHD changes, for example, performance on a neuropsychological test of attention. And it's another thing to say it changes a person's life in the real world. And those studies actually haven't done that yet. They're important for us to know that exercise can have this impact, but it's not something we should view as a replacement for other treatments for ADHD. Absolutely not. We also don't know the pathway. For example, it could be that people who exercise sleep better, because they're sleeping better. If you sleep better, your cognition is better. We know that. And that's something we also need to figure out, is what the actual pathway is for that effect to occur.
Yeah. Actually, sleep, we both know that. I usually often say to patients that sleeping well in ADHD is of paramount importance, and it's hard to even get the medication dose right if the patient doesn't sleep well. I have some patients who work
Yeah,
who work during the night, and I sometimes I say you should change
yeah,
your work, because
right.
it will be very difficult, if even possible,
That's right.
to get the medication right.
Yeah, I mean, people should understand the brain has an internal clock called the circadian rhythm that affects how you need to sleep. And for example, we all know there are some people, we call them night owls, they stay up late at night. Other people are, we call them morning larks, they get up early in the morning. Their brains are a little bit different in terms of their internal clock. And it's generally not good to try to fight your internal clock. If your internal clock says you need to get up early, you just should follow your internal clock and not try to fight it. So my recommendation is really that, for people just to try to maintain a regular sleep schedule that fits well with how your internal clock works, and don't try to fight it. I mean, the ideal situation is that you go to sleep at night, you get a good night's sleep, and you wake up without an alarm clock. Because if you need an alarm clock to wake up, it means you're not getting enough sleep, and you need to. Right? I mean, I'm not
Nice
saying
point. Yeah.
an
Yeah.
alarm is nice to have just in case you don't wake up, but ideally, you don't need your alarm clock. So,
Right. Right. And the fifth paper, this one is kind of funny. I will tell you why in a moment. Neonatal surgency moderates the association between the home environment and executive functions in children with a family history of ADHD. I'm laughing because I will have a hard time. We will translate, of course, for our Polish audience. We will translate this, and I will have a hard time explaining what surgency is. Um, could we say responsiveness to the environment? It's a little bit more, right?
well, it's used as it's kind of we call it temperament, a predisposition that a person has, which is related to having lots of energy. Impulsivity is part of it, having kind of enthusiasm for life, tendency to be more positive than negative, very cheerful, very sociable. That's a surgeon person.
Yeah. So, like I said, so it's difficult to explain. That's what I meant. That
Yes,
it
it is.
it requires some sentences. Let's call it. Okay. So well, the paper says that there is a correlation between neonatal surgency, so this reactivity, positive reactivity to the world, let's call it like that for the moment, and the environmental factors on executive functioning. Um, can you make it simple?
It's not a simple paper, honestly, to understand. What it's
Okay.
saying is that the impact of the environment on executive functions. Well, we have to unpack this for people. Unpack meaning make it a little simpler, understandable. So when we say impact of the environment, that's very broad. It could mean things like chaos in the family environment. We know lots of family conflict isn't good for ADHD, as one example. It could mean poverty. Some of the stresses of living in impoverished environments probably are not good for people. Executive functions are part of how we think, how we control the world around us with our brain. One way to think about how we regulate our behavior. So what this group is saying is that the environment impacts the ability of people to self-regulate. So, for example, many of us know that if we're in very stressful environments, we're less organized. We're a little bit more. We're more chaotic too, just because there's so much happening, so much we have to respond to. And what they're saying is that it's different for these people who have this surgeon temperament. I'm not really sure how important that is. It's kind of interesting to know. It's not a big effect, but it does show the complexities that we're dealing with these. Now they're also thinking, surgency is a little bit related to ADHD because of the impulsivity side of it. And I think if we want to think about it in practical terms, it's really, I think it's good for people listening to understand how the environment might affect their ADHD. Because, first of all, we can throw one thing out right away. There is this belief on the internet that because of these high stress environments we have nowadays, that causes ADHD, or
Yeah.
people using
Yeah.
tablets cause ADHD, people
Yeah.
using AI causes ADHD. And I can tell you, having been doing this work for almost 4 decades now, every time something new comes out, it causes ADHD. TV causes ADHD, et cetera. Right?
Okay.
And that's not true. There's no, and we also know that the prevalence of ADHD is pretty consistent around the world, both in high, if you will, chaos environments. Well, not high chaos environments, but high technologic environments and lower technology environments. So we're not talking about cause here, but we're talking about events that can make things worse for a person. And any stressful type of environment where there's lots of, if you will, pressure on the person to do something in different ways, that's going to be hard for anybody. But it's a little bit harder for somebody for ADHD, because remember, ADHD is one way to think about it is we have difficulty regulating by ourselves how we feel about things, how we think about things, and what we actually do. And so we're going to be more impulsive in a high stress environment because our self-regulatory capacity isn't very good. And that's why, as I'm sure you do, we always recommend to patients that to try to think about the environments that they put themselves in. And, some environments aren't as good for them as others. So a job that requires them to be in a very high stress environment might not be the best thing for them, just like working at night might not be the best thing for that person. And that's something that the healthcare provider and the patient have to work on together, because it's not always easy to figure out what that's like, for sure.
Yeah, yeah. That's why in our clinic, psychoeducation is the place where they think about it,
That's
how
right.
the environment affects the symptoms.
That's right.
As you had said in the beginning, one of the points that the person must check to be diagnosed with ADHD is having negative effects of ADHD. And in some environments, I might not have ADHD.
That's right.
Right?
That's right. That's right.
So,
that's right.
Yeah, I think that this is a part of the, as we both know, that there's a discussion whether there's such a thing as late onset ADHD. And I think this is one of the ways to respond to that simply environments change and my hormones too.
That's right. And we also know there's been some studies that show that if you follow people up over time, that some people go in and out of their ADHD. It gets worse, It gets better, it gets worse. People who have really severe ADHD, they tend to have the problem all the time. People who are milder, though, they can go above and below the threshold, if you will, of diagnosis. Yeah. And you're right. It has to. We believe very much it has to do with the challenges that the environment places on our abilities to regulate our own behavior and our own emotions. That's really what it comes down to. And so, yes, it's really important that people with ADHD keep track of that, of their environmental. I mean, the obvious thing is an environment with lots of distractions is going to be very hard for somebody with ADHD, because it's by definition they're more distractible, and it will be worse for them, for sure.
Thank you, Stephen, for explaining. As usually, it's been very valuable. I hope this is not the last time that we meet to talk about papers on ADHD.
I enjoy talking with you, Eric, and you do a good service to the people in Poland, and I'm sure around the world are listening to this. I think that's great. I'm going to give them another reminder about my website, adhdevidence.org. And I do want to say also that this is totally free. There's no charge. There's no paywalls or anything. It's meant to be a public service for people to get what we call evidence-based information about ADHD. I always tell people, believe in the science. Don't believe what some guru says on the internet or what some TikTok personality tells you. It's mostly wrong. And in fact, there's actually data about that. When people have studied TikTok, they find that most of what is said about ADHD by so-called influencers who are not experts is just wrong. So please make your decisions based upon evidence, not on personalities that you find entertaining and enjoyable.
based on science. Thank you very much, Stephen, and see you hopefully. Bye.
You take care. Bye-bye.